Hi, my name is Shelby. I'm a student nurse at Cedar Crest College. I'm presenting today a critique of spirituality and spiritual caring, nursing perspectives and practice in palliative care and acute care settings. This was written by Susan Ronaldson, Lillian Hayes, Christina Agar, Jennifer Green, and Michelle Carey. The research problem was identified as spirituality being difficult to explain and spiritual care being difficult to articulate. The lack of universal language made it hard to define spirituality as well as to describe for an individual's care for an individual's spirituality. The other problem they ran into was that nurses' own spiritual perspectives affect the spiritual care that they provide for their patients. There were 6 research questions. Do perspectives of spiritual care differ between palliative and acute care? Is spiritual care practiced in both palliative care and acute care settings? Does the practice of spiritual care differ between these environments? Do the nurse's personal perspectives of spirituality influence practice? What are the barriers to providing spiritual care? And do personal perspectives and spiritual practice influence these barriers? The purpose of this study was to compare the spiritual caring by palliative care nurses and acute care nurses. The aim of this study was to compare spiritual care practice between acute care settings and palliative care settings, determine correlations between perspectives and practice, and to identify possible barriers to spiritual care. The significance to nursing practice is that a nurse's perspective affects the delivery of spiritual care. Spiritual care is growing in the nursing field and expanding widely. Spirituality is an integral part of holistic nursing care for the mind, body, and spirit of patients. It's a difficult area to articulate and discuss. It can differ based on the environment that the nurse works in, and the need for education in acute care environments is significant. Okay, the framework and the variables for this study include there's no theoretical framework, there's no conceptual model, and there were no interventions. The variables, the independent variable was the environment that the nurse worked in, so acute care or palliative care. And the dependent variable was the relationship between the RNs and their personal beliefs in spirituality, and how those personal beliefs then influenced their practice of care. A sample was taken of 92 nurses from Sydney, Australia. 42 were palliative care nurses. These came from 4 separate organizations. 1 was a community health palliative care service. 3 were hospice care settings. And 50 acute nurses were taken from 3 different metropolitan area hospitals. The inclusion and exclusion criteria. Palliative care nurses were recruited from hospice and community care services. Acute care were recruited from general surgical floors, orthopedics, and coronary care units. Permission for participation was granted by the director. No nurses from high dependency units were recruited for the study. Ethical components. Permission was granted by the director of the hospital for participation and advertisement, and ethics was granted. Data collection. The director gave consent and the manager handled recruitment and participation. The data was collected over a course of 6 months. It started with a self-completed questionnaire that asked demographic questions such as age, specialty, amount of time in the specialty, education, prerequisites, sex, and then basic background questions. It then used the tool of the Spirituality Perspective Scale, or SPS. This measured the view of spiritual impact on personal life, and it used a Likert scale from 1 to 6. The last piece was another tool called the Spiritual Care Practice Questionnaire, or the SCQP. This measured the frequency of assessments and interventions for spiritual practice and barriers to providing care. This also used a Likert scale from 1 to 5. The study findings were that palliative care nurses had higher spiritual perspectives, and that acute care RNs ranked a little lower. The author did note that they believe the difference in these findings were due to the palliative care nurses being older with more experience. Their mean age was 43. They had longer employment, which their mean year of employment was 18.3 years. And they were also in their specialty longer, with their mean of that length of time being 9.5 years. They practiced spiritual care at advanced levels compared to acute RNs. Acute RNs had the mean age of 33 years. They were only employed for 9.6 years, and they were only specialized for 6.6 years. Study limitations and barriers. The limitations were that the RNs were recruited from a specific number of acute care environments, and it limited the diversity. A large-scale hospital was not included, and this also limited the population used. It was recommended by the author that a bigger hospital be used. Barriers. The most common barrier between that both the acute care nurse and the palliative care nurse noted to providing spiritual care was insufficient time. Acute care nurses also noted that a lack of privacy was equally as high to being a barrier to completing spiritual care. The least common barrier noted was that there would be criticism from peers. So, implications for practice. Document and discuss spiritual caring with other colleagues. Raise spiritual awareness and reinforce by education in ongoing programs and education, specifically to acute care programs. Identify nurses' perceived barriers to spiritual care. Overcome barriers to spiritual care. Further research for acute care settings. Support from experienced nursing mentors. Conclusion. The palliative care nurses have increased perspective and practice of spiritual care due to age and increased experience. Acute care units would benefit from more support and addressing these barriers. Spirituality is vital to end-of-life care, and spirituality is important to consider when caring for the individual as a whole. These are my references, and this concludes my presentation.